So first off, thanks, Teresa, Suzanne, Alan, Greg, Howie, Cindy, many others for all the contributions to these various forums, including these motor forums. And I think it's worth, again, emphasizing also that the knowledge that most older people, especially those who have cognitive symptoms, have multiple proteinopathies as well as some vascular component to their cognitive or dementia syndrome. So UDSv4 is meant to expand what we can gather by clinical phenomenology as well as the biomarkers. So I'll focus the next two talks on the motor phenotyping, and the thoughts here were to try to do a more diligent job in characterizing the motor contributions while also minimizing burden to the participant, the study partner, and the study staff, including the clinician and the clinician who fills out the form. And hopefully this has struck a reasonable balance. So this is going over the UPDRS, and this is the traditional UPDRS. So the purpose of this form is to determine the degree of Parkinsonism on any visit, as well as track the degree of Parkinsonism over time. And the definition, this should be obvious, but loosely defined for NACC purposes, presence of bradykinesia, rigidity, tremor, or any other features suggesting extrapyramidal dysfunction. The UPDRS is not intended to establish the presence or absence of Parkinsonism. It can be used to derive that, but that's a little bit debated. But again, it's quantify the degree of Parkinsonism and track that over time. So the instruction for this form is to be completed by the clinician or another trained health professional. And the clinician should record the results regardless of whether there are non-Parkinsonian contributions or explanations for the findings. And I'll expand on that more in a minute. For those who may be a bit rusty on the motor exam, or for new people who join any program for training, this is a very good article that Joel Muter published about 15 years ago. And for those who haven't seen it, this publication, it's easy access. And there's two videos associated with this. So you can see how to perform the UPDRS motor exam by video. So it's be a good training video. So this is page one. There's 4 pages for the UPDRS. And to look at this a little bit more closely, so first to signify whether the person was seen in person or not, because one has to examine tone and do the pull test for postural instability. You really can't record a valid UPDRS via video or phone. So this is meant to be in person. The instructions I just went over, and then each of the 27 items on the UPDRS is a checkbox, and you just check one box per question. For a lot of people, if they have a normal exam, this should be easy. You just check that box shown here, that if the full exam was done and it's all normal, check this box and you're done. If there are any elements of Parkinsonism, then it is important to record it. So looking on others on that first page, characterizing speech, facial expression, tremor at rest in the face, lips, or chin, right and left hand. Note that for every one of these fields, there is normal, which is 0. 4 is the most severe aspect of that finding. 8 is for untestable. And we're hoping that this won't be used much, but it is appropriate to use the untestable box when the person, for example, has an amputated limb, or has obvious sequelae from stroke, or has a cast from a recent limb fracture. But again, hopefully the untestable box will not be used often. And I know this may be a little bit hard to read, but other aspects of the UPDRS, tremor at rest in either the lower limbs, action or postural tremor in the right hand or left hand, rigidity in the neck, either arm, either leg, finger taps, and importantly with the motor exam, and again, Joel's videos go over this, but at least 10 times of rapid movements of the fingers or of the hands or pronation, supination, at least 10 times to get a sense of a decrease in frequency and or amplitude. Leg agility is assessed in the legs, and then a person is asked to be sitting in a chair, fold the arms across the chest, and stand. That's used for assessing arising from the chair. Posture, gait, postural instability with the pull test. Again, a good example of the pull test is shown on the video. And then overall sense of body bradykinesia and hypokinesia. And then at the end, so there's 27 elements. At the end, as long as there's no untestable box scored, then there will be a value. And this is basically the sum score of the UPDRS. It's often used as a quantitative assessment of the degree of Parkinsonism. But if there's one or more boxes with an untestable score, then this should be rated 888 because it with incomplete data, we don't want that test being used without the maximum score being eligible, 108. So it's a pretty simple exam. A lot of clinicians are quite familiar with this. This is the traditional Stanley Fond version of the UPDRS published many, many years ago. This was used in UDS version 2. It was dropped for a few regions in version 3, but resurrected for UDS4 in part because we just don't have a good motor exam phenotyping measure. And so this was brought back in for UDS4. We strongly considered the Movement Disorder Society UPDRS scale, but after a lot of discussion and debate, we thought it'd be best to use the traditional UPDRS because there is an expense to use the MDS UPDRS, even for an NIH-funded program. There are copyright concerns. One has to do certification to do the MDS UPDRS, and there's a cost associated with doing the certification. And so all things considered, it was thought that the traditional UPDRS would be a better way to go. The sites can still use the MDS UPDRS. A lot of sites do already. And there are mechanisms to pull the data from the MDS UPDRS into the standard UPDRS, but depending on your local database capabilities, that can be easier said than done. But the Form B3, though, the traditional UPDRS is expected for all the sites. So just to reiterate, the motor exam, it is expected to be done on all ADRC participants when evaluated in person. Usually this is completed within less than 5 minutes. It can be done in less than 2 minutes in many individuals. And it doesn't take long to complete the B3 form. It usually can be done in less than 2 minutes. If it's a normal exam, it takes 5 seconds just to check the box. There's no formal certification required, but each site should determine mechanisms for training of staff and for promoting consistency and reliability of recorded data. So for, again, some sites have people who aren't trained in neurology per se, and it's going to be left up to the site to do training for the staff and for the site to be comfortable with those staff members doing the UPDRS. So thanks, and I'll stop there. Any questions, feel free to contact me or any other member of the team.
Hey, Brad, there's a question from John Ringman about, if someone's not testable, so I'm assuming like they can't follow commands or, and so if that's okay to label them as untestable.
Yeah, that's another good example of where you can't complete it.
Thank you.
And again, to reiterate, it's rate what you see on exam. And so, and there's debate on this issue too. The old traditional UPDRS, it was encouraged to rate what you believe as a clinician is due to real Parkinsonism. In the MDS UPDRS, now the rating is rate what you see. And there's pros and cons with either approach. It was thought it would be best to rate what you see using the traditional UPDRS. It's going to be hard to dissect out non-true motor components for people who may not be a lot of experience with using this measure.
So the question is, if arm swing is reduced, DT rotator cuff or cervical conditions, would we still mark that?
Yes. Again, there's two ways to do this, but the suggestion for UPDRS going forward is rate what you see, even if there is a musculoskeletal component.